Let's discuss antiphospholipid antibody syndrome. It has basically three components, which is thrombosis, pregnancy-related complications, and antibodies that form the main component of the criteria of the antiphospholipid syndrome. It's an autoimmune disease, and the clinical features of the thrombosis, which is venous thrombosis, arterial thrombosis, and microvascular thrombosis, with the pregnancy complication. Pregnancy complication are in the form of recurrent fetal losses, or in the form of preterm delivery, or in the form of placental insufficiency. The most important thing is the antibodies that are forming the criteria for the antiphospholipid syndrome. The antibodies are basically three important antibodies: lupus anticoagulant, anticardiolipin, and beta 2 glycoprotein. Among these three antibodies, lupus anticoagulant is mostly associated with the SLE, and the anticardiolipin antibody is the most common antibody that is present in the antiphospholipid syndrome. The other name for antiphospholipid syndrome is Hughes syndrome or the familial lupus anticoagulant syndrome. It can be divided into the primary and secondary categories. You will say the primary APLS when there is no associated other related disease. In the absence of other diseases, this is primary APLS. And whenever there is concomitant autoimmune disease, most commonly SLE, this is forms secondary APLS. For the true APLS, you have to remember the true APLS definition. If you have one out of the two clinical criteria and one out of the three lab criteria, the APLS is called as true APLS. The clinical criteria, as already discussed, are thrombosis and pregnancy related, and the antibodies, three antibodies are lupus anticoagulant, anticardiolipin, and beta 2 glycoprotein. For the antibodies labeled as positive, you have to repeat the antibodies on two occasions, which is 12 weeks apart. This is very important. Next is, it is more common in the females. Associated diseases is SLE most commonly. Other associated diseases is rheumatoid arthritis, Sjogren, and systemic sclerosis. These are connective tissue diseases that are associated with the APLA, but don't forget to remember the infections which are also associated or triggering the disease, which is syphilis and Hep C. Okay. Next very important term is Sneddon syndrome. For the Sneddon syndrome, you can remember Sneddon by an easy mnemonic, Sneddon itself. S is for sudden onset. It's sudden. And for net-like rash in the form of livido reticularis or livido racemosa. E for elevated BP. D for, it's basically histopathological changes, dermal arterioles showing an arteritis. Then N for neurological problems in the form of seizures or cognitive decline. And the late onset, there is dementia also. Then comes a term, triple positive APLS. Triple positive APLS is a condition when there is all three antibodies are positive. Your beta 2 glycoprotein, lupus anticoagulant, and anticardiolipin are positive in the triple positive APLS. It has poor prognosis. In the pathophysiology of the APLA, there is neutrophilic infiltration because there is a neutrophil activation. So interleukin 8 is important in the pathophysiology, and the pathway involved is mTOR activation pathway. So mTOR inhibitors are going to be beneficial in the APLA. Some things are stimulated in the pathogenesis of the APLA, and some are down-regulated. Stimulated things are monocytes, endothelial cells, platelets, complement, E-selectin, and tissue factors. Down-regulated things are tissue factor inhibitors, fibrinolysis, annexin fine-binding protein to phospholipids. If we talk about the history of the APLA, there are clinical episodes of arterial, venous, and small vein thrombosis, and there are pregnancy complications as already discussed in the form of one or more unexplained deaths after 10th week of gestation, one or more preterm births of the normal fetus before 34 weeks of gestation, or three or more unexplained spontaneous miscarriages before 10th week of gestation. So two things are based on the 10th week. After 10th week, unexplained death, and before 10th week, unexplained spontaneous miscarriage. This is one thing, and one is 34 weeks. Before 34 weeks, normal fetus death is in the absence of preeclampsia or recognized features of the placental insufficiency. Another important thing about the skin findings of the APLA is in the form of thrombophlebitis, purpura, ecchymosis, livedoid reticularis racemosa, vasculopathy, necrosis, gangrene, atrophy blanchis, subungual splinter hemorrhages, anetoderma, purpura fulminans, and important complication is CAPS. We are going to discuss it later on. So, avascular necrosis and hemolytic anemia is an important complication. Nephropathy, which is also known as lupus nephropathy, it is also a complication of the antiphospholipid syndrome. 1% of the APLA patient develop CAPS. What is CAPS? It's 3 or more organ developing within 7 days in the patient with persistently elevated APA. The organs can be renal dysfunction with hypertension in 70% of the patient, pulmonary thromboembolism, pulmonary hypertension in the 70%, cutaneous manifestation in the form of livedo, necrosis, gangrene, purpura fulminans, or neurological manifestation in the form of seizures, infarcts, encephalopathy, or venous occlusion, or cardiac manifestation. These are all the components of the CAPS. CAPS can be triggered by infection or any other identifying trigger like trauma, surgery, anticoagulant withdrawal, but the infection is most common one. And if patient has SLE and APLA, it's a poor prognostic factor. If we talk about the prognosis of the antiphospholipid syndrome, it has poor prognosis. One third have the organ damage, one fifth are unable to perform everyday activity. And there is increased risk of stroke in the younger individual if the patient is known case of APLS. Whenever you are dealing with a patient with the APLS, you have to find the drug which can be triggering factor. For drugs, you can remember the drugs in the form of HAPI, HAPPI. H for hydralazine, A for amoxicillin, P for propranolol, P for phenytoin, and I for infections. Infections can be syphilis, Lyme disease, tuberculosis, leprosy, hepatitis A, B, HIV, cytomegalovirus, Epstein-Barr virus, and COVID virus. These are important things to remember. For the management of antiphospholipid syndrome, we divide the management into different categories. One is the risk modification. Second is the primary thromboprophylaxis. Third is secondary thromboprophylaxis, and then treatment of complication, which is CAPS, pregnancy prophylaxis, and the treatment of non-criteria manifestation. So we will going to discuss it one by one. The first was modifiable risk factors. The modifiable risk factors are same for SLE like hypertension, hyperlipidemia, diabetes, smoking, or any other trigger like exogenous estrogen. You have to avoid all these things. Second is the primary prophylaxis. Whenever you find a patient with a positive antibody profile of APLS, you have to start the patient for the aspirin, 75 to 100 milligram daily prophylaxis aspirin. And if the patient has concomitant SLE as well, then aspirin plus HCQ is the preferred choice. Some studies say that the vitamin D and statins also are important in prophylaxis, primary prophylaxis of the APLA. For secondary prophylaxis, it is important to start warfarin. Whenever you have to start the patient on warfarin, you have to set some INR target. If the patient is having APLS, first venous thrombosis, which is unprovoked, then your target is 2 to 3. But if patient is having arterial thrombosis, the target is 2 to 3 or 3 to 4. But if the patient is having recurrent arterial or venous thrombosis despite taking aspirin or warfarin, the target is increased to 3 to 4. You have the option either to increase the target and add aspirin, or you change to the low molecular weight heparin. These are the two options. Then, as discussed previously, mTOR pathway is important in the pathogenesis of the APLA. So, sirolimus is also important in the management of the APLA patients. For refractory cases, rituximab is an option, and for patients with the CAPS, you have to give the triple therapy. Triple therapy in the form of rituximab, or in the form of heparin, high dose glucocorticoid, IVIG, plasmapheresis, and in the refractory CAPS, you have to give rituximab and complement inhibition via the eculizumab. So this is the treatment ladder for the APLA patient. Primary prophylaxis is in the form of low dose aspirin, 75 to 100 milligram daily, asymptomatic patients. Secondary is in the form of heparin or warfarin in non-pregnant patient. If there is a pregnancy, then warfarin is not the option, is teratogenic. So heparin and low dose aspirin combined is given. Second line is oral tannin inhibitor. An important thing to remember about the oral tannin inhibitor, it's not given in the arterial thrombus or the triple positive APLA patient. It's only the option in the venous thrombosis or the patient with the single or double positive APLA. Then low dose HCQ can be combined in the patients with the SLE. Third line treatment, there is IVIG, rituximab, and refractory cases, plasmapheresis can be given. So it's all about the APLS.